Cycling. Okay, we are live. We are live. Hey, everybody. This is Dr. Kadisha, your board certified emergency medicine physician, and I'm here today with special guest, Dr. Ken Richmond. Dr. Ken, tell us about yourself.
Hey, I'm Dr. Ken Richmond, board certified psychiatrist, veteran, and corporate leadership coach. I'm happy to be here with you all. I help corporate leaders pinpoint their leadership issues so they can develop thriving workplaces with less turnover, improve workplace morale, and increase organizational performance. But today I'm here wearing my psychiatrist hat. So Dr. Kadisha and I are going to talk to you a little bit about today's topic on anxiety.
And guys, come on in, welcome. Do comment, let us know that you're here, and definitely share, because the anxiety is real. I have to say that, anxiety it's an occasional expected part of life. You might feel anxious when faced with a problem at work or a problem within a relationship or before making an important decision, but anxiety disorders involve more than temporary worry or fear. So for a person to, and it can get worse over time. So the symptoms can interfere with daily activities such as job performance, school performance, and those relationships. And we are seeing that more than ever during this pandemic. It actually literally kept me up for 24 hours from 6:30 a.m. yesterday morning to 6:30 a.m. this morning. The amount of anxiety that I saw was astounding. It was astounding. Hey, Victoria, thanks for joining us. So, what we want to do, because people come to the ER with anxiety presenting in so many forms, from mental to actual physical forms that we can see. We want to talk about the physical and mental manifestations of anxiety, and we're going to go through like a couple scenarios to get the discussion going, but definitely please share your comments and experiences in the chat. Okay, so I'll tell you about one patient that I had. Okay, so imagine this person. Imagine you're driving and you have the sudden onset of chest tightness, numbness and tingling in both hands, even around the mouth. And you feel like your chest is tightening around your heart to the point that your heart is about to explode. At the ER, we do an EKG. It's normal, but your heart rate it's a little elevated. It's like 120. And of course, you have no hypertension, diabetes, high cholesterol, heart disease, or anything like that because you're just 19 years old. I come in, we talk about your feelings. I know they're real. I can see it on the monitor. Your heart is beating 120 times a minute. You're sweaty. You're a little shaky. But we talk about it. Your heart rate goes down to 103, it goes down to the 90s. And in order to help keep you calm, should you not be able to control it yourself, I write you for a small prescription for Ativan and advise that you follow up with your doctor. So, Dr. Ken, what typically happens after we discharge such people from the ER in this case? What would you say?
It is surprising that the person came in, they had the full workup, everything was negative, they got a medication, you send them home, and let's say they see me in the office, right? They may say they don't need to be there. Imagine that, right? So they can really, despite everything being negative, they may still believe something physically is wrong with them. Mm-hmm. They may need a second workup. I'm not sure what other workups you're going to do if you already did the EKG monitoring and that was negative and all the labs were within normal limits.
Yeah, all the labs were normal. Mm-hmm.
Yeah, sometimes they still may believe that they don't have anything physically wrong with them. So in other words, for them to get to that understanding of having a psychiatric or a psychological issue, sometimes it takes a little bit of, you have to develop some rapport with the patient, with that individual, right? But also getting a good understanding of what their triggers may or may have been, if they know it, or if it's unprovoked. That's a harder type of discussion to have. But sometimes, yeah, the medication will help, but it really depends on what happens in that session when they follow up, if they do.
Gotcha. And do you have um, like more people coming from the ER or like their primary care physician's office? Because sometimes we hear a lot that primary care physicians handle this, but what kind of patients do the primary care physicians send on to you?
So that's a very good point. A large proportion of psychiatric care is delivered by primary care providers, or at least, a lot of those, the diagnoses and the presentation is found in the primary care setting. The more acute presentations would obviously go to the ER, and then they meet you, Dr. Kadisha. But more often than not, the primary care doctors are, working with and managing patients with similar conditions. When they reach a point where they've tried one or two medications, or they're uncomfortable with that patient's presentation, they would refer to a behavioral health specialist, whether or not that's a psychiatrist, a nurse practitioner, a physician assistant. They would refer for a more specialized treatment for that individual.
True.
Yeah.
And what would some of those be like? Okay, because I'll admit, in the ER we typically prescribe Ativan. What other medications might work if Ativan doesn't help them?
Yeah, so there's a whole host of medications we can try. And first you have to figure out if it's anxiety, what's triggering it, right? Because I usually tell patients, if it's an external issue, medications cannot treat situations. Medication can treat symptoms, right? So I'm always clear about that from the get-go, right? What are your symptoms? And then we add on top of that, what are the situations that are contributing to that experience? So more often than not, we have diagnoses of generalized anxiety disorder, which is typically somebody who is constantly worrying. They can't shut their mind off. The example I use is, when you have your fancy car and you put it in the garage and you turn the key off, you turn the ignition to the off position and take it out. What happens to the car?
It should relax. It should be off.
It should be off, right? However, but for some individuals with anxiety, their brain is continuously going. So that even though the key is on the ignition, i.e. they're trying to lay down and trying to sleep, their mind is, what I call, doing these mental gymnastics. It's going from one thought to the next, one subject to the next, and that becomes overwhelming. So you can imagine that person is not sleeping if they have that much distress or that much that many symptoms going on.
Got you. And you are right. So in the ER we do have the great pressure of making sure that it is not anxiety. We have to consider a number of things that it could be, because anxiety can present like you're having a heart attack. It could present like you're having a stroke with one-sided numbness and tingling. It could even present as GI issues, abdominal pain, diarrhea, even allergic reactions. I know people who get hives when they when they're having anxiety. So the onus is on us first to rule out life-threatening causes or immediately treatable causes before we hang our hat on the diagnosis of anxiety.
Correct.
And we also have the onus. The onus is on us also to not make the patient think that we are not taking their symptoms seriously. And we know that people get irritated in the ER all the time. They say, "Oh, you don't think that what I have is real?" And sometimes we may not communicate ourselves in such a way that you feel like you're being taken seriously. And that is something that I will say that we do have to keep in mind. So things that we have to rule out are, yes, we're thinking about heart attacks, blood clots to the lung, the AKA pulmonary emboli, electrolyte imbalances, low blood sugar, low or high electrolytes, things like that. We do keep those things in mind before we diagnose you with anxiety. Okay, so let's go into scenario number 2. And before I go into scenario number 2, I want to welcome Dr. Dietrich, Dr. Carol, let's see, Pastor Johnny Johnson. Actually, he was a police officer in the St. Joseph's ER here in downtown Houston, where I used to work, and my mom, Marlene. So, hi guys, thanks for coming in.
Thanks for joining us.
We will go into scenario number 2. Okay, so it's Sunday. It really is Sunday, and you're preparing your to-do list for the week. You might be getting ready to watch Strategy Sundays with Dr. Chen in a few hours. You know, that's part of your Sunday routine. Right. But you experience the onset of nausea, and your bowels feel like they are twisted in knots. You want to race to the restroom, but you're afraid to move, to the point where your spouse has to take you to the ER, where you're just sweating profusely. You may vomit once, you have diarrhea. Your vital signs are normal, except again for that elevated heart rate, and in this person, elevated blood pressure. But you're in so much pain that we start an IV, we give you fluids, we give you GI medication for the nausea, the cramping, we do blood work, even an abdominal CAT scan. All of that is normal. And we discharge you with prescription for those GI meds, because we think that it is like maybe a stomach bug or something. Mm-hmm. And we just refer you to your primary care doctor. But your primary care doctor, after seeing you for a couple of times, they might drag this out for, I shouldn't say drag it out, but the visits occur over a period of a couple months, and everything is normal. Everything is normal. And they tell you it's anxiety.
Huh? Isn't that frustrating though? That's frustrating, but the key point here is that there's a pattern every Sunday. I know in the military that happened quite a bit, not just in general, but mostly in the military, because that's why I started most of my when I left residency. That's where I started out. There was always this complaint of this intensity in terms of the stomach is in a knot, they're nauseated, they're losing their hair, they're losing weight, and they can't really explain it. And come to find out, they're in these high stress jobs, high performance jobs where they can't afford to take a day off. They can't afford to be sick. Although, the ironic thing is that they are having some physical symptoms. Mm-hmm. Right? Anxiety can really present with some gastrointestinal issues, like the ones you mentioned. And again, it's hard to explain, because let's say this person doesn't eat breakfast. Let's show you how complicated this can get. Let's say they don't eat breakfast because their stomach is now in a knot. Let's add on top of that the fact that they're diabetic. Right?
Oh, yeah.
And they're choosing when and how to take their insulin to manage their glucose. You see how complicated that can get, where now they're even anxious to take insulin because it may drop their blood sugar, much lower than what it needs to be. So again, it's just one of those things where we have to recognize, one, the history, the pattern, as well as the triggers. If it's the start of a work week, sometimes folks are just fearful of their boss. They're fearful of the workplace. I mean, right now that's pretty understandable, if you don't feel like you're going to be protected. Or if you're going into a work setting where you're not sure what it's going to look like. Is it going to look like a war zone? Is it going to look calm? Like, imagine, you just came off a 24-hour shift. What was your anticipation of your shift? Smooth sailing, up all night, a little time when you can sleep. That level of unpredictability always creates an instance of increased anxiety. I usually tell you, the more known elements you can have in your life. So the more things the more factors that you know about, the less anxiety you're going to have. Here's an example. You're going to a gathering. You don't know anybody at this gathering. What are some of the questions you're going to ask?
Oh, let's see. Who are these people?
Who are they?
Yeah. How do you
Oh,
know the person you're going with? It's like, how do you know this person? How do you know this person? Yeah. Why is
you
this
would,
person looking at me
yeah,
like that? What? Yeah.
you would go through the 20 million questions. By the time you hear those questions, you're just like, you know what, let's just not go anywhere because this isn't worth it.
It's not working.
Yeah, because that anxiety can cause you to ask questions and it can make you ask questions repeatedly. Even in the healthcare setting, right? If you met, and I do this often with, let's say anxiety, because anxiety can affect anyone. So anxiety in the geriatric population. Okay, so let's imagine a geriatric person having cognitive issues, memory issues, processing issues, understanding information. They need some time to understand that. When we meet them, what do? We say, how are you today? Is everything okay?
Yes.
That was literally two questions that you asked that person. They haven't even had a chance to answer the first one. And sometimes we get into our own routine of just doing that and just like, I think I'm okay. What was the second question you asked? They're just stuck on that. But when somebody's anxious, they can really rattle off questions. Who's going to be there? What kind of food? Do they know about allergies? Is it a park? What's the neighborhood like? Who's driving? All these other things what route are we going to take? That's somebody with severe anxiety to the point of panic disorder where they cannot function. The level of anxiety that they're experiencing really impacts how they function in their life. They can't go to work. They can't go to school. How could you imagine working if every time you have a panic attack, you have to leave? An employer cannot sustain that.
Right.
Effectively, you're not reliable. You're not a reliable employee in a setting like that. That creates a lot of anxiety, not only for that individual, but also the unit that they're working in or the department that they're in. In a healthcare setting, if we had a provider who has severe anxiety and when it happens, they have to leave. If you're the only doc on shift or one of two docs on a shift, like you really just created a crisis, an emergency situation because of that symptom. So that's how impactful the anxiety can be to someone's livelihood.
So true. And I've seen that happen numerous times during the work week where someone has to bring their coworker. So like you said, there's been an emergency situation created on the job because usually it's nowhere near medical. It's, it's an office somewhere. Everything comes to a halt. Everyone rushes to that poor person. That can cause more anxiety having, your acquaintances and coworkers standing around you. And then it takes not just that person out of the workplace, it takes the coworker who, has to take. So you often have two people who are gone for a number of hours. And of course, the patient often doesn't come right back to work. The other person might come back, but they're in such a mental state after being in the ER for a couple hours. It's just like, they're no good. I could just imagine.
Right. Yeah. It's sort of contagious, and to your point of somebody appearing anxious or having a panic attack, and one of the things that they need to do or feel the need to do when they're feeling anxious is the need to escape their environment, to just kind of remove themselves from the situation. So even our best effort to console and help that person can provoke more anxiety, because now you have a whole bunch of people coming around them. So now that space that they thought they had to escape is now blocked. And usually if somebody is blocked or you're trying to restrict them in some way, just the instincts is going to happen that they're going to attack or feel the need to defend themselves or try to escape. And that's why you see people fighting quite a bit. They're just saying, like, let me go, I need to get out of here. They can't really say more than that. They can't get their thoughts together enough to get a coherent thought out, but except to say, I need to get out of here. And what our tendency to do is say, no, you can't go. You have to hold them down. And that's something that just makes it worse. Really, really makes it worse.
So what would you advise for, if you were speaking to a group of people, working for a company, what would you advise, or how would you advise they handle someone in their workforce having an anxiety attack? Because the likelihood is high that, it's just so common. How would you advise that a group handle that?
So as you know, in healthcare, we always err on the side of prevention, right? So, workplace, family life, whatever that situation is, you always focus on what are the stressors. If you know, for example, in a workplace, you're going to be having a very intense project, or you just came off of a previously intense project and you're jumping into another one, you have to be able to check in with your folks to know, hey, what's our baseline level of functioning? You know, who needs to take a break? Who has not taken a break? Right? Whose vacation days are in excess and spilling over that they can share it with anybody else in the department, because they don't take breaks. They just keep going and going and going. Right. So I would say, you have to be able to set some objective measures in place to see how folks are doing. Whether or not that's we have a questionnaire called the Generalized Anxiety Disorder Questionnaire, a GAD-7. It's like 7 questions where you can just have people do anonymously. Hey, let's just assess the response of our unit. You don't need names to know that your anxiety is high in a department. Because that's always a fear, right? When you talk about anxiety, psychiatric conditions, there's always that stigma that's associated with it. So if there's any way to minimize that, you just have an anonymous survey. Hey, we want to know what the anxiety level is like in our unit. Let me give you these 7 questions: 0, 1, 2, or 3. Let me see where we're at. That gives you a good baseline of where things are, right? And usually people respond to questionnaires and surveys when it's anonymous than when they have to put their names on it. We obviously did this in school, right? Why put your name on a feedback for a professor when you can just do it anonymously and hopefully something change? But yeah, some anonymous way of doing some rating scale to see what's the pulse of that unit, or of anxiety in the workplace.
And I totally agree. It's and that's how we function in the ER. We imagine what the worst case scenario could be, and we focus on how to handle that as a team before it happens. People ask us, how do you deal with, what comes in, at any time, since there is that level of unpredictability or uncertainty. It's because we anticipate and we prepare, and everybody participates. So you participate in the preparation.
Right.
Okay. Oh, Dr. Yvette McQueen, I love that name, says vacation is Bay.
Yeah, she's a travel doctor, so she would know. We have to take time to decompress. We have to take time to decompress. We can keep going and going and going, but at a certain point, our body, if we don't stop, our body's going to stop for us.
Well said. Well
right?
said. Well said. But we just keep thinking, oh, well, let me do this. One more thing, one more week. Okay, I'll do it next week. I'll take a vacation next week. And I'll really because this is what I do. I'll say, oh, I can really relax if I can just get these other things done first, because I won't be able to relax unless I get these other things first, taken care of. And it just gets pushed back further and further and further. So,
yeah. And I can tell you, sometimes patients even ask me, what do I do to relax, right? How is their mental health provider being able to decompress after a day where you may see, I don't know, upwards of 17 patients a day on the worst case scenario, what is that like, And you probably saw some posts where I did stuff and delegate, I go to the beach, I go for a walk, I get my sleep. Well, hopefully. I mean, that's just a hit or miss. That's still debatable how many hours of sleep I need, right? I try my best to get into a routine where I'm able to be fresh and attentive when I'm in a session with a patient. You can imagine going to a session with somebody who's anxious and they're just like, oh, what was that?
That was me at 3:00 this morning. I don't have to imagine.
Yeah, but that could be tough. That could definitely be tough. And what if that patient wants to leave? Let's say they came to the ER, you said everything is fine, and it was like, well, I guess you can't help me then.
So, and unfortunately, that's kind of when, like Dr. McQueen might not have meant for this situation, but if the person is, if they are, of sound mind and body, there's no physical life threat going on. They are not a threat to themselves or others. then we can't hold anyone there against their will. And that is especially an issue if a family member has brought that person to the ER thinking that we're going to, just eliminate the entire problem. And, we find that they're normal, or that their blood work and, EKG, chest CT, all those things are normal. And there's no, especially now, like we can't admit as freely to the hospital as we used to with all the COVID patients and things like that. So, we do have to be more conservative with just admitting people to the hospital. And so that, there's that. And the person might actually just be stable for discharge and follow up with their mental health professional or primary care physician. And the family member is like, no, like they're not good right now. It's like they know who they are, where they are, the date, the president. They're not suicidal. They're not homicidal. So we can't hold this person here. And let's see. Dr. Yvette says, right, we filter out the medical reasons for the anxiety. That's what we do. And we make sure that there's no life threat to you, and that you're not a threat to yourself. And then we typically have to let you go to follow up. And, we will prescribe you that, Ativan. We're not trying to snow anybody. It's just to, calm you down. And we can't hold anyone there, even if you don't think they're right. Sometimes they are stable. They're not the way you need them or want them to be. But
yes. And that interaction, as brief as it is always an opportunity to educate a patient on, what they came in with. Just a discussion on anxiety. I can't tell you how many times I may have a discussion with a patient who they may say, I've had anxiety for years and years and years, and no one's ever asked me X question. No one's ever told me X, Y, and Z. They quickly most of what they would say is they just give me a medication and hope that it works, right? So that just sets up a bad expectation for patients when it comes to managing, a psychiatric symptom that is very distressing. And I can tell you, sometimes anxiety could be to the point where folks don't feel like living. So to your point that, if they're not actively suicidal, anxiety is still one of the common symptoms associated with folks who may attempt suicide, right? You can imagine, again, you can't quiet your mind. Your muscles are tense. Your chest feels tight. Your heart is beating out the side of your chest. Your vision may get blurry. Your hearing may go in and out. Headaches. You have numbness, tingling sensations happening. You're sweating all the time, right? You can't sit still. You always need to be pacing or running around or doing something, right? At some point, you just can't, those individuals who, and especially if they're not seeking help, they really, really feel overwhelmed and distressed by those symptoms. And then we have to worry about, like you said, the suicidal thoughts and other risky behaviors that they can engage in as a result of that.
And to that end, just to follow up on that, so the person doesn't explicitly say or admit that they are having, suicidal thoughts or whatever. I mean, what else can we do if they don't come out and let us know? I mean, is there something else that we could do in the ER?
Yeah, so you have a few options. You have the option to let the patient go after you've assessed them in terms of determining their risk. You can call a psych consult, a psychiatric consult, or a mental health consult, depending on the resources available to your institution. There are local resources. Some states have crisis response units that are able to come and do an independent evaluation and determine if that individual is safe for discharge or do they need to be hospitalized. And ultimately, if the decision is for that individual to be hospitalized, you have voluntary admission, which is basically saying the patient is agreeing to seek further treatment at a higher level, a psychiatric unit, for example, or involuntary. And that's where things can get a little bit more complicated. And that could be a whole, other talk on that topic. But that's where, either two physicians can agree that this person needs to be in the hospital, And legally we're able to do so. Every state has a different term, there's a 50-51 in some places, a 302 in some places. So it's just different rules, but the concept is that it's an involuntary commitment, which means that someone other than the patient is stating that the patient or that individual needs to be in a safe environment or in a psychiatric setting. So police officers can do that too. So that's my.
Gotcha. And yeah, I have had police bring people in for that express purpose. Actually, definitely, it's been a while. So Victoria has a question of what would you say to a young Black man in his early 20s who's getting a lot of anxiety with the daily occurrences, especially when the sounds of sirens are heard in their driving?
So what would I say? I would want to know first what's the context of that? Why are those sounds so triggering to that individual? Okay. So ideally is making sure they're connected with a provider. So whether or not that's a family member, a therapist, their primary care provider, somebody who they're able to, at least somebody who's able to start teasing out the A to B to C to D, like what is the sequence of events that's happened to that individual where that is now such a distressing experience for them. Oftentimes we worry about things like PTSD, post-traumatic stress disorder, or just post-traumatic stress symptoms, acute stress disorder, acute stress symptoms. Again, just because somebody's had a traumatic event doesn't necessarily mean that they're going to have PTSD. At the same time, trauma is defined by how the person perceives it and how that trauma has then affected them being able to function. It is still an anxiety-driven process. You still have the tension that can happen, the racing thoughts. But it's really just a matter of getting to the root of what the source event may have been for that individual.
Gotcha. Thank you so much.
That question is also complex because, the Victoria says it's a young Black man. So you talk about stigma, right? A Black man going into a community mental health center, a therapist's office, that's usually a big ordeal for them to even want to show up. And even when they show up, it's another ordeal for them to open up about what they may be experiencing. So a lot of it depends, what is their experience with providers in the past? Because otherwise, there's a tendency to just hold all that information in and hold all that distress in. And then before you know it, it's coming out in ways that are not healthy.
Great. Thank you so much for that answer and for that question. It sounds like we may have to do some other episodes talking about PTSD and being a Black man or just a Black person in the U.S.
Yeah, it's a big deal.
And also involuntary commitment, especially with the things that have been going on in the media. There's been a lot of talk about what that person's rights are and what your rights might be as a family member when you feel that person is unstable. So we are at 33 minutes and we don't want to, we don't want to go on and on, but let's see if there's any. So yeah, bottom line is, we have ER doctors, we can get consultation, after we rule out those life-threatening somatic causes of symptoms that can, like anxiety. We do have other resources, but like Dr. Ken said, prevention is the best thing. And if you feel like you may have an emotional issue, seek out help before you end up in the ER, because in the ER, we're going to do those things, rule out, heart attacks, life-threatening causes, electrolyte imbalances, things like that. But then after that, if you are not, actively suicidal or homicidal, a threat to yourself or others, then the visit typically ends right there. And we give you, an anxiolytic, meaning a medicine for anxiety, and then we refer you on. And I'm sure you want more than that outside of an ER setting. Dr. Ken, what take-home messages would you like to share?
So again, appreciate you for having me on to this broadcast this evening. So I think that the take-home messages for anxiety is going to be that it is treatable. Yes, there are medications that can help, and you mentioned at least one of them. Therapy, the combination of the two, but also things you can do just in your life. So whatnot, that's exercise, monitoring what you eat, just meditation, having some healthy routine. Those are things you can do as well to help manage your anxiety.
Yes, meditation, other forms of relaxation, whatever you like to do. Yes, exercise has a great effect. Meditation is wonderful as well. And the combination of those things, like Dr. Dietrich said, the approach to anxiety should be a multifaceted one, and you can get a bit from all of these things. Okay, guys, so thank you so much for joining us. Hopefully we can have another, do more episodes like this where we approach different parts of mental health. This is National Minority Mental Health Month, but mental health is important every month. And thank you for joining us. I'm Dr. Kadisha, your board certified emergency medicine physician. Do follow me on Instagram at Dr. Kadisha MD. That's Dr.Kadisha_MD. Of course, you're here on my Facebook page. Thank you so much. Do follow, comment, and tell me of other topics you'd like to discuss. And thank you so much, Dr. Ken.
Thank you. Thank you for having me.
Take it away. So tell us where we can find you, what other resources that you offer to us.
So you can find me on Facebook. So www.facebook.com/Dr. Ken Richmond, DrKenRichmond. You can visit my website, www.drkenrichmond.com, for additional information in terms of stuff I would do in the workplace. It's also a way of just reaching out to me. If you need to get up my schedule, we can do a strategy call, strategy session if you're in the workplace or human resources. But as well as patients. So eventually I'll be rolling out a telemedicine platform in terms of services in a few states. So that's something that's in the works. So hopefully folks will be interested in working with me in that way as well.
And he also has the book Mental Blocks.
Yeah, my book, Mental Blocks, A Concise Corporate Guide to Employee Mental Health. It's really a resource for folks in the work setting to put words to what they're seeing, to be able to describe behaviors that they're seeing in their employees, colleagues, subordinates, so that they can get them to the help that they need in a timely manner than in this reactive process that we always seem to be caught up in.
Okay, awesome. So hopefully you'll come back, Dr. Ken, and grace us with your expertise as we approach other mental health issues. And guys, thank you so much for joining me here. Definitely continue on in the comments, continue to share, and let me know of other things you would like discussed. And join Dr. Ken later today for Strategy Sundays so that you can discuss the best ways to approach the work week, because the workplace is definitely a large source of anxiety. And until then, let's see. Well, and then we'll see you later. Thanks, guys. Bye.
All right.